Hello everyone. Today I am going to tell you the details of iron chelator agents. In first video I have already explained about the blood transfusion. Second principle of management in thalassemia major is iron chelation therapy. Because of regular blood transfusion they are having the excess iron overload in the body. So today I am going to cover all about the iron chelation therapy also. So what are the indications, what are the various iron chelators available, what are the doses and side effects, how to monitor the side effect and toxicity, the role of vitamin C with the iron chelator and monitoring for the overchelation. Indications of iron chelation therapy. Chelation should be considered after 1 to 2 years of transfusion when the serum ferritin is more than 1000 nanogram per day or hepatic iron is approximately 7 milligram per gram dry weight. So these are the two indications. We start on the basis of serum ferritin more than 1000 nanogram per day. What are the various iron chelators? Desferrioxamine or deferiroxamine, desferal or DFO. Deferiprone, trade name is Kelfer, dimethyl hydroxypyridine. DEFERASIROX and available as a Desferriox, Asunra, XZ, ICL 670. There are various newer iron chelators. So I am going to tell you the details of all these iron chelators. So first is desferrioxamine, DFO. It is the gold standard therapy and most effective and safe iron chelator. It is given subcutaneously over a period of 8 to 10 hours daily for 5 nights a week with the help of desferal infusion pump. And the dose is 20 to 40 milligram per kilogram per day, available as a 500 milligram injection. For the infusion of desferrioxamine, we also need the desferal infusion pump because it is given subcutaneously. Though it is gold standard for the management of iron overload, but it is not very popular in the developing countries and hardly used in 10 to 15% of thalassemia patients in our country due to its high cost and cumbersome technique because we have to give 8 to 10 hours daily subcutaneously with the help of desferal infusion pump at least 5 days in a week. Desferrioxamine desferal can also be given intravenous, but by the central line only when the patient is having the severe hemosiderosis to prevent the or to reverse the cardiac toxicity or already patient is having cardiac dysfunction because of iron overload. High dose will be required 3 to 9 gram daily. It is useful with the subcutaneous infusion, but close monitoring will be required when we are giving the intravenous, and we cannot give more than 12 or 24 hours intravenous. It is also not easy to maintain the central catheter, and there are chances of infection also. How to prepare the subcutaneous or intravenous desferal? It is available in the form of powder lyophilized. So 500 milligram and 2 gram is available. We have to take the distilled water 5 ml for 500 milligram, 20 ml for 2 gram. So the final concentration will be 100 milligram per ml and the dose is for the subcutaneous 20 to 40 mg per kg per day. We have to check after reconstitution that this desferal solution should be isotonic clear, colorless to slightly yellow solution. We should completely dissolve it before withdrawing it, and we should reconstitute with sterile or distilled water for injection. We should discard the unused portion. Now, what are the toxicity of desferal? Local reaction. At the site of subcutaneous, local pain, induration, irritability, redness can occur. Visual abnormality seen in 4 to 10% patient. Patient can have the decreased acuity of vision, peripheral field vision defect, defective or dark adaptation, abnormal visual evoke response, cataract can develop. High frequency sensory neural hearing loss seen in 4 to 38% patients. Growth retardation in children below 3 years of age. If we are starting the desferal in less than 3 years age group, mild skeletal abnormality as short trunk, sternal protrusion, genu valgus can occur. Sometimes severe yersinia or mucormycosis infection can occur. Rarely pulmonary infiltrate, renal toxicity occur. Tachyphylaxis when given parenterally due to histamine release, leading to bradycardia, hypohypertension, rigors, headache, feeling cold, hot, photophobia, or zinc deficiency can occur due to desferal. So whenever patient is on desferal infusion, we should monitor for the side effect and toxicity. So for auditory and visual toxicity, which are reversible, yearly slit lamp examination and audiometry are mandatory to detect them early, and if we found the patient is developing any side effect, then desferal should be stopped. We should also measure the create and urea level every 3 months for the renal toxicity. We should also calculate the growth velocity, and we should measure the sitting height every 6 months to assess about the truncal shortening, which is the side effect of desferal. Now, what is the role of vitamin C with the iron chelator? Thalassemic patients with the iron overload are frequently vitamin C deficit, as seen by low leukocyte and serum vitamin C levels. So we should give them vitamin C tablet with the desferrioxamine infusion, because its effect also increase with the vitamin C, and they are generally vitamin C deficit also. So vitamin C supplementation increase the desferal induced urinary iron excretion around 20 to 25%. Then we have to monitor for the overchelation also. If you find persistent ferritin level is less than 500 nanogram per ml, we have to repeat at 3 months interval. If it is less than 500 nanogram every 3-month interval, then patient will develop the increased toxicity and side effect of desferrioxamine whenever there is a low ferritin and low total body iron level. In this condition, either we should stop the subcutaneous iron chelator and switch over to the oral only, or we can decrease the dose 25 milligram per kilogram per dose or less than this. So daily we have to give less than this, and we should also go for liver biopsy. If liver biopsy also suggests that patient is having decreased hepatic iron, then we should stop the desferrioxamine. Zinc, copper, selenium, ionized calcium level should also be examined, as these are the other indicator and suggest about the desferrioxamine toxicity, because level of all these will be altered. Now the oral iron chelators. There are two oral iron chelators. One is deferiprone, Calfer. Dose is 75 to 100 milligram per kilogram per day divided in 3 to 4 doses. And it is 70 to 100% as effective as desferrioxamine. And toxicity, there is no evidence of ear eye toxicity. Kidney and liver function also remain normal with the deferiprone. Now the side effect of deferiprone, some GI symptoms, nausea, vomiting, abdominal pain, diarrhea can occur. Arthropathy is the main side effect of deferiprone, seen in 20 to 30% children. So whenever we are starting this drug, we should explain to the parents that if child is having joint pain after starting this drug should be stopped, and they should come to us and we should either reduce the dose or stop it. It primarily involves the large joint. It is the most common side effect and it is reversible when you stop or reduce the dose. If drug is not discontinued or dose is not reduced, it can lead to the permanent destruction of joint cartilage. Irreversible damage to the joint will occur. So it is the side effect which should be explained to the parents also. Agranulocytosis, absolute neutropenia can occur with this drug. Thrombocytopenia can also occur. And drug-induced lupus is also rarely can be occur with the deferiprone. Now the assessment of deferiprone side effect, physical examination of the joint and CBC including the neutrophil and platelet count must be done regularly whenever child is on deferiprone therapy. Another oral iron chelator is DEFERASIROX. Trade names are Desferrioxamine, Asundra, XZ, ICL 670. Doses are 10 to 40 milligram per kilogram per day orally. So whenever thalassemic patients are having the ferritin more than 1000 nanogram per ml, we are starting the DEFERASIROX at the dose of 10 milligram per kilogram per day. And if patient is not maintaining between 1000 to 2000, even more than this, every 3 months we have to repeat the ferritin level. Then we increase the dose of DEFERASIROX up to 40 milligram per kilogram per day orally. It should be given as a single dose in morning. If patient is not maintaining serum ferritin less than 2000 with DEFERASIROX, then we add the deferiprone with DEFERASIROX. So these two drugs we can give combined. If patient is not maintaining with these two oral iron chelators and ferritin level is persistently more than 3000, then we start the subcutaneous desferrioxamine desferal. So deferacirox is first choice of oral iron chelator. It has a half-life of 11 to 16 hours. It should be given once a day, empty stomach, at least 30 minutes before food. And its tablets should be dispersed by stirring in a glass of water or apple or orange juice 100 to 200 ml before taking. Must not be chew or swallow whole. So we should explain to the relatives that tablet should be dissolved in the water or in juice at least 100 to 200 ml, then child should drink it. It is 5 times as effective as subcutaneous DFO and 10 times more potent than deferiprone. So it is the drug of choice as a iron chelator. Now the side effect of deferacirox: GI discomfort, abdominal pain, constipation, diarrhea, vomiting, rarely skin rashes, mild non-progressive increase in serum creatinine can be. So we should go for renal function test. Neutropenia, thrombocytopenia can occur. No change in auditory, visual or cardiac function with the deferacirox. Now the combination therapy, we can give the deferiprone with the desferal or deferacirox with the desferal. So deferiprone 75 mg per kg per day for 5 days in a week, with desferal 30 to 40 mg per kg per day subcutaneously over a period of 6 to 8 hours on weekend for 2 days. It is more efficacious in reducing both liver and heart iron. Combination therapy is based on principle of shuttle hypothesis, as one chelator, deferiprone, mobilizing the iron from stores in the tissues, while the desferal help in excretion from the bloodstream. Similarly, we can give the deferacirox 10 to 40 mg per kg per day daily with desferal. Both are having the synergistic effect, help in reducing dose of both the drugs, thus improving the compliance and cost of treatment. In this also, shuttle effect is seen as the DEFERASIROX act as a intracellular chelator, while the desferal as a extracellular helpful in excretion of the iron which is present in the bloodstream. In newer iron chelators, these are under trial, not approved, not available. But for theoretical and generally asked in the Viva also, what are the new iron chelators? So you should remember at least the name of these iron chelators. Desferrioxamine, it causes the kidney damage on prolonged use. Another is 40SD02, a starch Desferrioxamine. This drug is synthesized by attaching the desferrioxamine to the modified starch polymer. Adverse events are pruritus, urticaria can be seen. HBED, hydroxybenzyl ethylene diamine diacetic acid. It is also given subcutaneously, twice as efficient as deferoxamine. GT56 252 orally active iron chelator, 2:1 binding ratio with the iron. And last one is pyridoxal isonicotinol hydrazone PIH. So these are the newer iron chelators under trial. So this is all about the iron chelators in thalassemic patients. Thank you so much.